If you're a DPC physician looking to refine your sales pitch, overcome objections, and confidently communicate your value, you won't want to miss our live virtual workshop on February 11th. Join Lauren Tancredi, a cash pay medicine expert with nearly 20 years of experience, as she shares proven strategies to help you sell your practice with confidence. Whether you're struggling with patient objections or just want to fine-tune your approach, this interactive session is designed just for you. Reserve your spot now at mydpcstory.com. Just head on over to the events page for all the details. And for more insights, go to the top of your feed right now to listen to our latest episode where we talk about quote unquote selling your practice in a culture where we still hear most patients say, "But I have good insurance." Now, let's dive into the episode. Today, get ready to be inspired by the amazing Dr. Aleea Gupta in this replay. She's a micropractice superhero, juggling 2 kids, a physician husband, and a thriving DPC practice, all without any in-office staff. In this episode, she shares her creative strategies for using social media to connect with her community and how she turned those contacts into patients. If you're looking for ways to boost your online presence and grow your patient base, this one's for you. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care to me means old-fashioned medicine brought into today's modern world. I truly believe it's the best way to practice in primary care, and I am so thrilled to be part of this movement. I'm Dr. Aleea Gupta with Family First Direct Primary Care, and this is my DPC story.
Dr. Aleea Gupta is a board-certified family physician who completed her undergraduate education at Duke University. She earned her medical degree at the University of Florida and completed residency at Overlook Hospital as a part of Columbia University. She has worked in multiple settings in the past 25 years, including as an assistant professor at the University of Southern California, a partner physician at Southern Permanente California Medical Group, and a staff physician at Doctors Immediate Care in Illinois. In 2018, she learned about the direct primary care model from a colleague and decided to open the first DPC practice in her county. She did not have a patient or referral base in her town and thus had to build her DPC practice from the ground up. Dr. Gupta used in-person and social media marketing to successfully fill her DPC practice in 3 years. Through trial and error, she discovered the key steps that DPC physicians need to take in order to use social media to get patients to join their practices. Dr. Gupta is also passionate about spreading awareness about the DPC model to medical students and residents. She has used social media to showcase the strengths and values of DPC and has lectured about DPC to several future physician groups, both virtually and in person. Her goal is to help further the direct primary care movement in Chicagoland, the state of Illinois, and beyond. Dr. Gupta is married to a retina surgeon, has 2 children, and in her free time enjoys reading, watching foreign films, and studying Spanish. Welcome to the podcast, Dr. Gupta.
Thank you so much for having me, Marielle. I'm so excited to be here.
You are back on the podcast. If you haven't yet checked out Dr. Gupta's podcast with Alex Torres in regards to marketing, please go check that out. But it was such a pleasure to share the stage with you at the DPC Summit in Kansas City. And I really love that people got a little bit of your story from your initial podcast as well as at the summit. But now the space is for you to really highlight you as a physician and to share more about your practice. So with that, I wanted to get into first your journey, because as was shared in your bio and your credentials, you've been all over the place, so to speak, in terms of growing up. You were moving to different places. In training, you've trained in different states and practiced in different states. So can you just bring us back to your entrance into medicine and how your journey eventually led you to your DPC?
Thank you so much for having me, Marielle. It is such a treat to be on the podcast. I'm a huge fan. I've just watched it grow and explode, and I just think what you're doing in this space is phenomenal. I'm glad you're getting all the recognition that this podcast deserves, and I'm just excited to see it spread even further through the DPC world and just the medical community in the coming years. So thanks again for having me. So I feel that I'm on the older spectrum of doctors in the DPC space. I turned 50 this year, and I've basically been in practice since the late 90s. Going back to my childhood, I think I was just destined to be a kind of a nomad or a gypsy. I'm originally from Guyana in South America. I was born there, and I'm the fifth generation of Indian descent in my family in Guyana. And there weren't a lot of opportunities for people in the 70s. You were basically going to be in whichever station you were born into. And my parents really wanted to look for other opportunities. And at the time, the Middle East was hiring. And so my dad took us across to Saudi Arabia. And I lived most of my childhood in Saudi Arabia, where he was teaching English to college level students. So I spent most of my childhood in Saudi Arabia and Iraq. And then when I finished school over there, we moved to South Florida. And that was my first entrance into the United States. But I come from a family that has many, many teachers, literally only one other physician who's about 10 years older than me and is a male cousin. So the idea of me becoming a doctor, to me, I was always an underdog. It was sort of like, a pie in the sky. There were no role models. There was no one else in my family who had entered medicine. And of course, this is now the 80s. In the 80s, as an immigrant, it was just kind of an unknown territory. I think my parents just let me apply to college. They never looked at my applications. There was no college counselor helping you with your essay. None of that. I just kind of filled them out and sent them in and saw what happened. So I didn't grow up thinking I was going to be a doctor. I went off to college just kind of interested in STEM. And then I fell in love with psychiatry. So I decided I'm going to med school to be a psychiatrist, and that's what I'm going to do. And then once I got there, I realized that it's great, but working with psych patients has a particularly unique stress because the majority of people you look after, you're going to have this alternate reality with them as patients. And you may always be questioning what's happening to them because the nature of the illnesses you're looking after are all mental health based. And so I wanted to round that out with just things that were more straightforward, coughs and colds and, gynae and all the other things we love in family medicine, but then of course still have the chance to do plenty of psych. So that's why in my fourth year, I shifted over to family med and haven't looked back since, and just always loved it. And then of course, after my father took me all over the world, I married a man who decided to do the same thing. So I did my training in Florida. We did residency in the tri-state area. Then we moved to California, got married there and worked there. And then after we started our family, decided that California is not only expensive, but where we were in LA, it's a tough place to bring kids up. And my husband was in an academic job and he wanted to switch out of that and move into private practice. So we looked around for the best job and picked up and moved to the Midwest, where we've been since 2008. And I think I'm finally rooted. And I told him we're not moving again until we retire. And so along the way, I worked in quite a few different places. And the thing I'll say looking back is from day one practicing medicine, I thought it was too fast. It was too fast. And it was clear from the very first day that what's valued is speed and volume. And you don't quite realize that towards the tail end of residency because academics tend to be a little bit more sheltered. And, by last year of residency, maybe you're seeing, 12 patients, in a day, or it's a very doable number. But then all of a sudden you go in your first job and the people who hire you are like, okay, you ready to go? It's 4 patients per hour. And if you can see 6 in an hour, that's ideal because, then we keep them moving. And, you hear things like, this doctor's so great. He can see 25 patients in a day. And I kept thinking, why are we valuing volume? Because the first time I had to see a patient that quickly, it just felt wrong. It felt like you're trying to cut someone's hair too quickly is the analogy I always come back to, sit down at the hairdresser and you say, cut my hair, and you only have 2 minutes to do it. How is that? How on earth is that haircut going to turn out? And that's how I always felt. There's not enough time. And so I started at University of Southern California. I took an academic job there for a year. And that was wonderful because in academics, you have lots of education and you have colleagues, and there's like a status to being part of a university. But unfortunately, in California, commute means everything. And my commute was an hour. And so I lasted about a year in that. And then I took a job at Kaiser, which is the large HMO on the West Coast. And I worked for them all the way until I had my son. And that's where I really saw what controlled corporate medicine is. And everyone knew that who worked at Kaiser. They knew from the get-go that you're going to be told what to do. You're going to have a lot of rules, and that's just the way it is. The benefits are great, the vacation, everything like that, but you were clearly told you may not prescribe a brand drug. Don't even try. If you try, you're going to get flagged. You may not refer to ortho or spine until your patient has done complete physical therapy, and you can't even order the MRI until they've done physical therapy. So there's so many steps, and they actually had a book of protocols for each specialty that we were supposed to refer to before we sent a referral. And as a young doctor, I remember a couple of times getting a nasty phone call from, GI or ID or something. Hey, did you know you haven't followed the protocol? Blah, 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 blah. And I'm like, all right, I'm new here. Let me get back to the book and read it. But just the idea that you could be part of a team and then you could be scolded by, your specialists, right? But anyway, I worked there. I became a partner, and then I had my son, and then we decided to leave California and move here. So then I started working at an urgent care, and I worked there for a good 5-6 years as well. And that was where I really learned the finances of medicine in terms of what's happening and how people are charged. And this urgent care was interesting because it was Medicaid based. So it was a primary care site for patients with Medicaid, and one of the docs was their assigned primary. But they also took walk-ins. They took people with no insurance, with insurance, and billed out. And they also broke it down into both primary care and urgent care. So it was a wide variety of patients that were coming my way. And as a mom with young kids, being able to work, 2 shifts or 3 shifts per week was great because you don't really bring work home. You go there, you see the patients, you finish, and you leave. But I would see what would happen when someone would come in with no insurance and they would want like STI testing, and the GC would be 125. And then the herpes would be like, I don't remember anymore, like 100. And I'd say, why are we charging them this much? And they'd say, well, that's the self-pay price. Of course, we know now that really a GC chlamydia culture is like $15, right? And then a herpes culture can be done for like, I don't know, maybe 20. So starting to see how prices are marked up really bothered me. And then also the quality of care that people get with Medicaid. So I was working with this low income population until one day I came in, and I'd been waiting for my paycheck for 2 months. It was like 2 months behind getting paid. And they're like, sorry, we can't pay you anymore. The clinic's out of money. Medicaid reimbursement is down. We just can't pay you. And that's when I had to leave, to make a long story short. So, leaving that environment put me right back into the question of, well, what am I going to do now? This is about 4 or 5 years ago. And so I looked at all the local medical groups, and I really wanted something that was possibly part-time, no inpatient, no call if I could get away with it, or minimal call. And those jobs just didn't exist. It was all or nothing. It's your privilege to join us and have us tell you exactly how to work and work exactly how we want you to work. And there's no part-time. And so that led me to Googling about concierge medicine and then direct primary care. And that's how I found out about the model.
I sit here listening to you talk about academic medicine, Kaiser, the Medicaid urgent care population. And I mean, wow, you have literally lived through all of that. And I think that really, we'll get to how powerful your social media platform is, but because of all of those experience, you can really see how you pull from those experiences when you talk to the future generations of DPC physicians. So it is so incredible again that you are here sharing your story, because you have so much to be pulling from when you started planning your DPC. So I want to ask there, because you said your husband wanted to do private practice. I want to ask, what were the conversations like when you and your husband were discussing you opening your own private practice, because he was already in that space?
Well, they were very interesting because he works for a large medical group that was since bought by private equity. And this is another interesting point that I think is unfolding in the healthcare landscape. And so it's been really eye-opening for me to watch from the inside how his medical group has evolved. And in the beginning, when we moved here and he joined, it was physician owned, physician run. It had a board, and it really felt like a place where they were multi-specialty, but they got to run things the way they wanted to until they were bought out. And once they were bought out, the culture changed. There's so much restriction. And I would joke with him and I'd say, it's turning into Kaiser. And he would say, no, it's not going to turn into Kaiser.
Wow.
Well, yes, it has completely turned into Kaiser, because it's the same thing. You can't, do certain things without clearing it or following the protocols. And what's most disheartening for me, just as a side note, but I think it's important to know this, what's most disheartening to me is how the finances and the compensation for the doctors has completely changed. They literally have to work harder to make less money. And I'm not making it up, because I hear about it from him all the time. Several of our friends work in the same group. So this is what we talk about on Saturday nights when we're getting together. We talk about the state of medicine and the state of reimbursement. But the problem is that many folks are in that mid space where they're about to send kids off to college, and not everybody can take the financial leap to open an independent practice. So to go back to your question, what we had around our house were, is this a viable model? How can we set it up in a way that if it doesn't work out, it's not a huge financial setback? He knew that you don't just open a practice and expect it to be filled right away. Because when he had joined the group, he had to get out there and bring patients in the beginning. And so he had a lot of experience from me in terms of, you're going to have time to set it up, but you're going to have to get out there and get your patients. They're not just going to find you. You have to go find them. And it's going to be uncomfortable, but you have to do it in order for the practice to fill. And then we use savings to get everything started. And then, as you know, a lot of folks do that, or they take out a loan and then you break even, then you pay yourself back, and then you start making a profit and you write things off along the way, is the simple accounting approach to starting your DPC. But the other side of it too is, I think for us in our family, we were in a position where the income is added on and would be fine. But if it didn't work out, and then I had to go and just swallow my pride and go find another urgent care, or suck it up and work for one of the big groups and take call and everything, we would have just had to do that. And then thankfully, it has worked out to where my DPC has now, year 4 in, it's met the financial goals that I was hoping for. And the reason I want to share this is because I'll share with you later how hard it was to fill it. But I really, really wanted to prove that I could make the equivalent amount of money in a part-time DPC compared to a part-time traditional job. I wanted to do that because I wanted everybody to know that it's possible, and it's possible when you don't have a panel of patients to bring with you. And so I'm really happy to share that, yes, it's possible. I hit that benchmark last year. And so this is how I know it's doable, that if I can do it, honestly, it's doable for people everywhere.
And I'm so glad that you mentioned that, because, again, you are in this space of being a very successful DPC physician. You've achieved your goals, and you are also making such an impact on the future generation, like I mentioned, of DPC physicians. And so the fact that you had been in all these roles, and you even had that mentality of if it works, it works. If it doesn't, we'll be okay. That is such an important place to be in headspace wise, because it really sets you up for being able to focus on the creativity, on the patient experience, on the ways to be able to, continue to practice autonomously as you're developing your DPC, whether you're like yourself, years out of residency, or whether you are just graduating residency in the summer. So incredible. Now, you mentioned it, so I want to go there next. In terms of filling your DPC, when you opened, did you have any pre-enrollment or did you start from zero? And how did you grow from there?
So when I opened, I had one patient, and I can mention him because he's so special. And I know he won't mind me sharing about him. He was an executive that had found me at my past urgent care where I told you they take walk-ins and whatnot. Great insurance, well-to-do. And he would keep coming back to this clinic just so I could be his primary. We had this strong connection. He's kind of like a father figure. And so when I got ready to open my DPC, I called him up and said, hey, I'm opening a practice. This is the model. Just want to let you know. And if you're interested or if you have any business tips. And he, of course, helped me business-wise. He was my first patient. He was there on opening day. He has since, I think the bulk of his family comes to me. But to answer your question, that he is all I had. The urgent care, as I mentioned, locked me out of their EMR. So I couldn't even go back and find a handful of patients to let them know that I was leaving and opening. So I had nothing. And it was also in a different geographic location than where the urgent care had been. So I literally opened with my one patient, and the plan to, we knew we would have to cover rent and the expenses of the practice until people came in and, started paying their membership. And it was quite intimidating. And I would hear stories of, DPCs that opened and, were full within 3 months, or that transitioned. And of course, I was happy for, folks who are doing well, but I was always also like, oh my God, what if it doesn't work? What if I never get patients? So it was intimidating.
And if you've seen one DPC, you've seen one DPC. So if you take your focus and your headspace and focus it on the things that you can control, and the joy that you have around opening your DPC, saving your medical career, saving your professional career, that will exude from your pores. So I will say that going into the future, this is one of the reasons why too, going to conferences in person is really important, because you really, or even visiting a local DPC, if there's one around you, not to compare, but to be surrounded by that excitement and other people exuding the love for this model and the love for creating a practice that is theirs. So I want to ask you, when you mentioned that extremely frustrating situation with the urgent care locking you out of the EMR, did you have any non-compete issues in Illinois? Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com, or check out the link in the show notes.
No, because again, that urgent care was so small, their contract was very lax, and there was no non-compete, but it was literally that I couldn't even track down the handful of patients that I knew might have been interested, because I couldn't really remember people's last name and stuff that's in the chart that there was no way to find them. So I had to come up with other ways to fill my practice.
What were those other ways that you used to fill up your practice?
So I started with joining my local chamber, and chambers are interesting because it was my first entry into the whole small business world. I have no business background. I was never interested in business, accounting, none of it. So I had always heard this term small business. I didn't even really put two and two together with what is a small business? How is that different than any other business? Why is this term? It just wasn't even on my radar. But then you come to learn exactly what small businesses are, all the different types, whether it's restaurants or boutiques or even, a real estate agent is a small business person many times. What that means in terms of how, they approach their work and how they get customers or clients, and how so much is based on relationships, and also the marketing side of it, events, why do we have, chamber events and farmers markets and all these things. So I joined the chamber and I gave it a year. I met everybody. I did events. I went to events. I sponsored events, and I did some printed media. And I discovered that that is very expensive and probably low yield for what you get. It's nice to do a photo shoot and be in a magazine and maybe run an ad, but it costs so much money, and it's to me, it's kind of uncontrollable. You don't know where the magazine's going, who's opening it, what will make them call you, what will make them do something. And so I started with that, and then I think then my husband said, you have to go door to door. You have to go door to door through your town. And I said, no, I can't do it. It's too embarrassing. I can't do it. He said, nope, make your business card, just go in there, say something, drop it off, and just do like 5 once a week. And so I started going around one by one, dropping off. I went to local salons. I went to the restaurants. I did get a couple people, from local places. But I think what I discovered is that social media gives you a chance to do some of that virtually, so that when you meet people in person, it's a lot less like cold calling. So if I go walk into the salon down the street and just walk in and say, hi, I'm the new doctor in town. Nice to meet you. Here's my card. It may not be received as well as if I had connected with that salon on social media and supported their social media, and then DM'd them and said, hey, I'm going to be in the neighborhood. May I stop by and say hello? In the sense they would already be expecting me. And then by the time I go in, oh, you're that doctor that always likes our posts. It's nice to meet you in person. Do you want a complimentary blowout while you're here or something? And then here's my card. I'm a great fit for small business owners like yourself because I understand how hard it is to buy insurance. Keep me in mind for some of your girls. Next thing you know, the owner would share it at their luncheon or their breakfast meeting. And then I would get patients like that. So to me, I figured out it's free and it's a way to bridge the distance between, my physical office and my space and their physical space.
I will mention this too, just with your example of the hair salon and the blowout. Even when you're getting your own hair done, I found myself getting my hair done, and the person was talking about how frustrating it is that, her husband is going to be in a position where their healthcare will change. I don't have a DPC in Modesto, but sure as heck, St. Luke's is in Modesto, and there's a doctor in Turlock. And so I was telling them, I was sitting there, what else are you going to do when you're sitting in the chair? Yeah. And I was pulling up their website. I'm like, this is the cost of their monthly membership. And the salon was filled with the what? And so, even that, I was thinking about you actually precisely at that point when the other, it was like little meerkats, the heads popped up and they're like, what is she talking about? And so, the word spreads, and like you're talking about, there's different ways to invest in your marketing, or, if you're already there doing your hair, whatever, it's a way to take advantage of that situation. When you mention efforts like print marketing and social media, I want to ask, as you were trying different methods, how were you benchmarking the success of each of those methods?
I'm kind of a Gestalt person. So I'm sort of like a big picture, and it's just the way my mind thinks, sort of look at the whole thing. And I kind of viewed it as different baskets. And I kept telling myself, you can't put everything in one basket. You have to diversify. And, you kind of start one, like maybe you do the magazine and then you wait and see. And then, you go door to door a little bit, and then you connect with a couple people. So I just kept filling the different baskets over and over as much as I could. And then I think I just kind of kept a tally in the back of my head about who was coming from where. But then I found, and this was probably maybe about a year in, I fell into what I think is probably the the ideal way to build your practice. If I had to go back and look at it again, I would probably go straight to this demographic and put all my efforts there. And that's finding local, like a group of local small business employees and owners that are connected somehow that will then spread by word of mouth for you. And in my case, it's the European community. I didn't realize that the trucking industry is extremely big here in the western suburbs of Chicago. And
Wow.
so probably 60% of my patients are from that demographic, and they are almost always word of mouth. And so they told me at the beginning, they're like, when Macedonian people find a doctor they like or a dentist, everybody comes to them. And I was
That's
like, oh my
awesome.
God, please let everybody come to me. Because you're just dying to fill the practice, right? And then they did, one by one by one by one by one. And so, and I know other people have gone directly to warehouses or directly to trucking companies and kind of pitched to the whole business. I never did that. I just ended up getting one by one by one, a friend and someone's brother and someone's mom and all that. But looking back, if I had to, I would probably have started there. I would have maybe skipped, the chamber altogether and just gone to some local places in my town and put my efforts into that one industry. Um, but things I also think I really feel the universe gives you, what you deserve, what you earn, and what you put out there. And so I have patients, from all sorts of different places. And to me, it also comes down to the relationships, right? Like the relationships you build with them.
Mhm.
And that's what I like, the fact that the practice is mixed. It just unfolded how it was going to unfold. And those who like it stayed and those who didn't like it or for whatever reason they left. And it just kind of over time settles into something that's more organic. But could you go back and target one group? I think that would probably be my little takeaway for somebody starting, is maybe identify that group and just go after it.
Awesome. And I think that especially if a person has already decided where they're going to open their DPC, that research can start before, the build out's done, before the website's done. You can start talking with people beforehand. So that's a huge gem. Thank you so much for mentioning that. As your practice has grown, can you give us a sense as to how many of your patients are insured versus not, and how many people are on a Medicaid type of plan versus not?
Sure. So I think probably maybe 10% are on Medicaid and then paying privately to be in the practice. And then of the other 90, it's probably something like maybe like 50-40 are uninsured and maybe 40 are. I'd say the bulk are small business owners without insurance. And then the second group are folks with insurance that like the DPC access and the type of care.
Awesome. So I want to touch on those two groups, the individual non-employer associated patients and then the employer groups. So when you have people who are insured, they're healthy, so to speak, and there's no known medical issues, and they're thinking about joining your practice. After you've done the door-to-door, meet and greets, you've done virtual meet and greets. What things do you say to people when they're trying to figure out if DPC is right for them, especially if they're insured and they're healthy?
So I'm always thinking about what would make the patient value being in the practice, because if they value it, they'll stay. And if they don't value it, they'll leave. Obviously, with the uninsured, it's the financial side. And I think that's the stronger hook, even if they're healthy, because they realize that one or two visits to urgent care is going to run them as much as a couple months of membership with no follow-up. And so it's almost a no-brainer if you're uninsured. But if you are insured, that's where I think it comes more to access and convenience, because the headache of calling a larger group just to make an appointment and then waiting for the appointment and then follow up or getting messages, we're in a culture where things move fast and everyone's busy. And so we all want to look after ourselves, but we don't want to take much time. And nobody is going to go sit in a waiting room for 2 hours, or, be on the phone for an hour to make an appointment. So I try to show them that in the beginning, that access, convenience, and availability and simplicity are part of how I do things. And I try to just make it very laid back Sometimes you'll get people that they just don't use medical services enough to justify it because, they just never come in. So it's kind of like, why would I? And that's the minority. But I found that, and this is the other thing I'm usually thinking is, do they have a reason to seek medical care? So if they have a couple of medical conditions or they're on a few prescriptions, they're going to need medical care at least twice a year. So for those folks, I know it's probably going to be an easy sell. I don't have a ton that are 100% healthy with nothing wrong with them. Because there again, it's, well, if I don't go to the doctor, why do I need one? And why do I need the convenience if I don't go to the doctor, right? So my young and healthy are usually uninsured or have a health share because they need me financially, right? But most of my insured they tend to be like around age 50 and older. So they've used some medical services. They have to come in once or twice a year and they see what the system is like and they don't want that headache. And they're happy to pay monthly to not have to deal with the headache.
And I just want to highlight on your FAQs, one of the things that I loved was that just addressing why would I need DPC as a patient? And you weren't necessarily addressing the young, healthy person, but just anybody who is looking into your model. We can prevent things from happening instead of waiting for them to happen. And I think about that phrase of, if you make time now to be healthy, you will make less time later to be sick. And it really highlights, again, that relationship-based medicine that is about knowing a person before the stuff hits the fan.
And sometimes you can get that across to younger people. Sometimes.
And for the other group that we were mentioning, the employers, I know that you found this niche of local truck drivers and it went out from there. But when you're talking to an employer, whether they be, an employer who has 2 employees or 25 employees or more, how do you start talking to employers in your area?
So I do have a couple of employees that were signed up by their employer, but I don't have any employer groups. By the time I think I didn't go after them very heavily. I got the truckers mostly again from them spreading it amongst their demographic one by one. I never went to the owner of a trucking company and pitched to them, although I think that would be great for anybody to do starting out. By the time I started to get into employer groups, I was getting close to being full. And I'll speak frankly here. I'll just give you my opinion that the employer price point for a large group, to me, detracts a bit from the value of what I want to give my patients. So if you pitch to an employer group and then you're going to make the youngest employee is going to be the price point of that group. So let's say you're going to, your tiers go from 60 to 100, but then you're going to offer the employer, everybody is a flat rate of 65. I personally think, you're losing money, right? Because if you had everybody join at their correct age tier, you would make more money and you may still have to do the same amount of work. And the older people they can be quite complicated. They can be heavier utilizers. So I personally shied away from giving a lower price point because I just didn't want to devalue what I'm doing. And maybe part of that is also because I'm still essentially solo and I've stayed solo. I have literally 3 or 4 hours of admin help per week, and that's it. And it's because I've gotten used to doing everything by myself. That was my philosophy. But now I know many folks have multiple employer groups, and maybe it works better for their arrangement and their staff and how they have broken down the finances of their clinic. So that was part of my decision not to really pursue them heavily. I also didn't want to offer them a flat price. I offered them a discounted rate per person, maybe like $10 off per age. And then just gave them, I said, that's what I want to do. And if they don't want to do it, then that's okay too, because I do think that in DPC, and we can speak freely here because the bulk of us, we're passionate about this model is so valuable. And what people are getting, the level of quality for what they're getting, I still think it's vastly underpriced. And so that's why I think that you really have to feel out your community. You have to have a price point where you're going to get some invisible patients. It's not so high that they feel they have to use it all the time, right? but then you're going to get high utilizers, and you can't have them and then be sort of upset because you feel like you're doing all this work and barely making $85 a month. So you have to find the right price point for yourself. And my hope is that as the model grows, that price point will be acceptably slightly higher because, yes, we're going against the grain. We're bringing something new to our community. We're fighting against the traditional system, but what we're doing is so much higher quality. Our 200 to 600 patients get way better care than 200 to 600 patients in a traditional practice, where the doctor has a panel of 3,000. So I think there's a value to that. And I hope that that's going to be demonstrated even more as people open more practices.
Amen. Cannot agree with you enough. Have you ever thought about the idea of charging per visit in addition to a membership fee?
It crossed my mind because I know that there are different models. And then I just kind of waved it away because then I started going down the sort of rabbit hole of, well, then what does that mean? And how do I decide who needs to get charged more? I'm not, I have been told that maybe you should discharge one or two of your high utilizers. It comes back around to the concept of what does the universe bring you? And I almost did it with one of my busiest patients. But then I thought, why don't I work on setting boundaries? Because boundaries are important in DPC. And this is something I think I had to learn. I think everyone learns as a small business owner is you have to set some parameters on how running this practice is going to affect your life and how looking after patients is going to be sustainable. And so that's where I found setting clearer boundaries on when I'm available, on when I check messages, on when I respond, on when I work on the practice. That helped me tame everything down and feel just better about all of it.
So important. And especially for those people who are wanting to open or who are already practicing as a solo doctor, these next gems I know that you're going to drop are so important to listen to. So when you talk about boundaries, what are your best suggestions for people as they're either opening or as they're adjusting their workflows to change the boundaries that have already been set between a doctor and their patients?
So the two that come to mind, one is start as you go, and the other one is don't overpromise. So in start as you go, I filled the practice little by little. I think at the end of the first year, I was up to 75 patients, and that's the number at which I broke even. So I was covering all my expenses when I hit 75 patients. Everyone has their number. But start as you go is more about think carefully about not giving too much, because you want patients so badly in the beginning. You'll take almost anybody, and then you want to do everything. So I did things like I came in on Sundays for working patients. I, came in the evening because they said there's just no way. And then I learned that if I kept doing that, that's not how I wanted to be practicing. So I was not starting the way I wanted to continue. So figure out, if you're never going to want to come in on the evening, then don't do it from the beginning. If you're never going to want to come in on the weekend, don't do it. And just tell patients, this is what I have. This is the times I'm available. And to that end too, don't overpromise. And again, it's so tempting because you love the model. You want, I'm available all the time. You can text me all the time. You can reach me all the time. No, don't ever say 24/7 because you do not want to be available 24/7. You don't, and you shouldn't be, right? Because what they think is 24/7 is not how we view being available. My EMR doesn't automatically do that, so we have to do it every night, but it's, I think, extremely important to have an auto reply on your texting line or your phone line, and you need to set those times and stick to them. So mine are 7 a.m. to 7 p.m. So when they join, I tell them at the intake visit or even before they sign up, I'm during the week, 7 a.m. to 7 p.m. Evenings and weekends are urgent only. And then that's what the message says. And if they forget and they send things at 10 o'clock, and the message has gotten sterner and sterner. Now it says, please do not text after 7 p.m. unless it is urgent. Because I don't want to scold people. And I mean, at the end of the day, they're paying to have me as their doctor, and I don't want to be contentious, but they also have to learn that Urgent is not, I need a refill, or I forgot to tell you when I wanted to have an appointment. No, that's not urgent. So I don't answer them. And then the other thing I do that is, it might be controversial, but it's gotten me this far, is I sit everybody down and I say, listen, after 7, if it's urgent, call me, but I'm going to bed at 10. If you call me after 10, I am going to say, what is the emergency? And if you can't answer that question, I'm going to get upset. And this is the only thing in my entire practice they ever will hear me say that sounds remotely stern. That's it. I don't get stern about anything else. And then their eyes get big. No, doctor, I would never call you. I would never call you after. I'm like, I understand. I'm sure you wouldn't. Just want to make it clear, because that's the one thing I'm not going to tolerate. And it is not appropriate to call after 10 unless it's an emergency. So I would put that out there, because I think we are, again, you want patients so badly. You want to do everything. You're tempted to bend over backwards and make it so easy. But then there will be people who take advantage of that. And then you will be in that uncomfortable position of having to then reset the boundaries or tell them, hey, whatever. So I just think it's better to set it out at the beginning.
Even when you go back to the 24/7, even though technically, you're describing a 24/7 availability with the understanding of after hours or on weekends are reserved for these particular issues, just by putting that on a website can be very dangerous, because that is your advertisement that you are available 24/7. So when you're crafting your copy on your website, it's something to think about, because you don't want to be then held to that 24/7.
Yes.
Dr. Phil Eskew highlighted that specifically in his My DPC Story episode from 2021. So I definitely would say, if you haven't heard that, Dr. Phil Eskew is the person who created the DPC Mapper. He is a lawyer, a DPC physician, and an MBA. So he knows what he's talking about. And the idea of boundaries, I think about in medical school, one of my attendings, he taught us the backwards walk towards the door as the clock is running out and you're like, I have to go to the next patient. And so just being preventing that situation where you are having to be reactive, like you're describing, is so important. So now I want to spin the tables a little bit, because when we talk about boundaries with patients, that's one thing. But what about boundaries when it comes to running your own business? What do you have to say? Yeah. What do you have to say about being a physician and an entrepreneur? And in your case, a mom of kids who are not yet off to college. How do you set boundaries for yourself and your business?
So it's hard, because especially when you start your DPC, everything is new. And it's so awesome that even though I didn't have much in the way of patients in that first year, I kept myself busy because I set everything up for myself how I wanted it to be. I did my whole office myself. Without a build out, I furnished it, I designed it, and then all of the other systems, Clear, your filing, your licenses, your everything. How are you going to track when you order labs and the results come in? All these little things, and you're marketing at the same time. So and crafting things for social media, which is a whole nother thing, all the content creation. So I think there's so much that happens that you just love it and you enjoy it. And so you show up to work and literally 8 hours pass and you're like, oh God, it's time to go home. It's, time to pick somebody up. And so I think part of it is treating it just like a regular work timeline, trying to confine it to daytime hours, trying not to let it spill into the evening, because that's a temptation, right? As we come home, we've had dinner, and then we're all on our computers watching TV. So I kind of take my cues from my family, because I do have kids who are doing homework. My husband is chairman of his department, so he's got admin things and stuff. So if other people are working and no one is really interacting or doing anything with me, I might do some extra in the evening. But I've learned that the family works better if I try to get things done before I'm with them. And if I put in a really full day, by the time I come home and it's time to wash dishes and help set up dinner and stuff, I'm ready for a mental break anyway. I do sometimes do some work on weekends. I'll do patient care maybe Sunday evening to kind of clean out the email box. I don't want patients seeing me replying to them. on Saturday or Sunday morning. But Sunday evening is kind of fair game. But when it comes to the business, there are those things that also, as the practice gets busier and you start having more patients to see, then you have less time for admin during the week. But the flip side is, at this point in time, because it's now been 4 years, there's not much that I'm creating that's new. All the systems are in place. All the workflows are as they are. I have very little, like settling the QuickBooks, going through the lab charges, paying the bills. It doesn't take up as much time as it used to. And sometimes I'll still squeeze it in on the weekend if everybody else is doing something else. Now, social media is another side because I have teenagers and they are on social media too. So I've learned that I almost have to make it seem like I'm never on it, because if I'm on it in their presence, then I have no standing. Well, Mom, you're always on social media, so why can't we be on it? Yeah. So to that end, I've also learned to put it in with the work and try to do it during the work day and set aside certain times so that I'm not there actively trying to post and do things where they can see what I'm looking at. Or I just, then I never hear the end of it.
Gotcha. Totally. Now, when you mention certain times of the day, can you walk us through Dr. Gupta's typical week in terms of what do you do on Mondays and when do you do certain things the rest of the week?
So I set the practice up to see patients on Mondays, Tuesdays, and Thursdays. And I make myself stick to that, because if I'm going to cap at a part-time salary, then I'm going to provide part-time clinical care. If I decided I wanted to work 5 days, then I would open my practice up and let it grow to where my income would match that 5 days. So I'm intentionally making myself keep my patients to 3 days a week. So what do I do? Typically in the morning, at this age in life, you have to help get all the kids off to school. So I do all that stuff and I multitask. So sometimes while I'm waiting for people, I'll do a first round of emails in the kitchen. And that kind of front loads my day so that by the time I've dropped everybody, including the dog, off at doggy daycare, I'm in the office maybe by between 9 and 9:30, but I've already done some of the first round of emails. So I'm not walking in there to a full inbox. And then I'll see patients. It just depends on the days. Some days it's summer. So right now the summer schedule's kind of odd, but typically till about 3-ish. And then I pick people up. Sometimes if I have someone to see again, I'll bring the kids back to the office with me, or I'll schedule phone calls. So once I've gotten home with them and they're in their activities, I'll do the phone visits in the afternoon. And I absolutely love being able to shift that on a whim, however I want to do it. It's priceless. It's absolutely priceless to be able to decide your workflow yourself and what works for you and the way you handle things. So that's, Monday, Tuesday, Thursday. Wednesday, Friday, I purposefully schedule no phone calls, no office visits, and I try to keep it to maybe less than a half a day of admin and follow-up. So this is when I'll do things like send out referrals that take some time to type up. Let's see what else, call a specialist or go into UpToDate and look up, a situation that's more concerning, because you can't always do those between patients on patient days. So sometimes I'll leave that stuff for Wednesday, Friday, but here again, I'm intentional that I do not want to be working all day Wednesday, Friday. So then if I have an errand, some type of self-care, I'll take care of it. I usually post things on social media on those days, so it's not really clashing with my patient days. But sometimes I'll, take pictures or record when I'm in the office because I want to catch the office space. And that's the day that I've washed my hair. So I want to
awesome.
do it on the day when the hair is optimal. but then I'll actually write things up and put them together and then put them out, usually on Wednesday or Friday or sometimes on a Sunday. Yeah. And then again, with the patients, I try really hard. If they don't, I never put my schedule on a website. It's not on the website. It's not on Google. Nobody knows, when I'm there, when I'm not. I just preferentially always try to keep them to a Monday, Tuesday, or Thursday, unless it's urgent. If someone fell or whatever, and you have to see them right away, you have to go in on a Wednesday, Friday. That's fair. But for everything scheduled, I try to stick to those 3 days.
Amazing. And very different than your experience at Kaiser and the experiences at the urgent care. So I want to go into your social media platform even more, because like I said, you have this unique place as a physician who has had all of this experience in being an employed physician to then opening your own DPC and then creating content that is very transparent about DPC. And it really highlights the autonomy and the things that we enjoy as DPC physicians. So can you bring us back to how did you get started on social media in the first place?
Sure. And thank you for those lovely words, Marielle. Thank you. So I started on Facebook when I opened the practice because everyone said this is how people are marketing their businesses now. You can get on and do these little Facebook ads. They don't have to be very fancy. And I had been on Facebook just with friends and family for a couple of years, but I never really posted much. And so I started posting things there just in terms of writing up about DPC, writing up about myself. And I was an English major in college. And I like to write. So that part of it appealed to me, but I have no experience in marketing. And so putting yourself out there and how do you present yourself in a way that's not egotistical, but also tells your story, who's going to be interested? How do you tell it in a way that will engage people who don't know about this? So it took a lot of trial and error and just trying, just putting something out there and just trying. And after a while on Facebook, I started to realize that it's an older space and it's closed because people won't really see your work unless they friend you and you accept their friend requests. So if you don't accept them, then they're not necessarily going to see much. And part of what we do as marketing is you want to reach people everywhere. You want to reach your potential patient, wherever they are. So somehow you have to bridge that distance. So I realized that unless you're running ads, Facebook, to my mind, was challenging. So, and everyone kept talking about Instagram. So I opened up Instagram and I realized that most small businesses use that platform because it's visual. You can display, the inside of your restaurant. You can display the eyelashes that you put on someone. You can put your work out there. But how do you put that out there as a doctor, right? Because you can't talk about patients. You can't show their pictures. I don't have really procedures and like dentists. So what am I going to say? So I kept just talking about DPC. And I also felt that that's great, but it's a little boring. So then I would mix it up with just things about life as a doctor, life as a small business owner. What does it look like to do this type of work? And what that led me to was meeting other small business owners who are trying to do the same thing on Instagram. And I've learned that marketing is all about relationships, and so is building your practice. So you may talk to somebody and you're just dying for them to sign up because, God, you want the patient, and then why won't they join you? And they don't, but they may go and tell somebody who tells somebody. And then a month later, their best friend or their sister calls you up, right? And they join. So you have to kind of just cast this net of relationships and content and just put it out there and kind of wait a little bit to see what comes back. But Instagram has that unique aspect of being able to really talk to people in the comments under their posts, message them and have them message you back. So you can start a conversation with people that then leads to meeting them in person. So that's how I came to social media to start. And then as my practice filled so this was around about last November, I was getting, I think last summer-ish, I got to the point where I'm like, I think I can start a wait list now. I'm comfortable where I am. People will leave. There's some churn. People will join, but I don't think I need to market DPC from my practice anymore. But like you and all of us, I love the model so much. And I'm so saddened by the state of healthcare that I thought it's my passion and it's my responsibility to give something back to this next generation of doctors and change this negativity that we have about the way medicine is. And again, I come back to like dinner table conversations. Well, I don't want my kids to go into medicine. Why would you want your kids to go into medicine? Medicine sucks. Going back, would you have done medicine again? No, I should have gone into business. This is the stuff you're hearing from other doctors, right? And yet we have this young generation that they have to do so much to get into med school. And then to have them graduate and kind of see what we have figured out on our own and that we have now decided to walk away from to open our DPC, right? So I wanted to be able to share that with future doctors and young doctors. And so around November, I made a conscious shift in my social media and I stopped talking to the potential patient and I started talking to young doctors, and I
Gotcha.
started connecting with them and posting about, why would you want to go into medicine? What is the state of healthcare? Why are independent doctors breaking away? What's wrong with corporate medicine? Did you know that when you sign a contract and you try to leave, you not only have a non-compete, you have to pay off the tail on your malpractice, and it can be six figures. Did you know that? So all these things that they don't know. And so that's how my intention changed. And it has honestly become something that is so enjoyable. It takes a while to figure out how to talk to different people and how to reach them, but just hearing them say things like, so is it possible to do this out of residency? Do you think I should work first? How can I find out more about DPC? Oh, I want to come to a mastermind. Oh, there's a DPC alliance, or can I shadow you? And just the interest and the fact that they're listening, I think, is what I hope for, is just this chance to be able to share this with those who I think need to hear it. And, I was joking with a friend the other day. It's like, what would Martin Luther King do nowadays? He would get on social media, because there's, think about it, compared to a march that's going to be on TV and be broadcast for however long, he would be on social media, right? Talking to everybody, because that's how you spread your message nowadays, if you can get to the people who need to hear it.
Definitely. And it really highlights how you can really democratize marketing, because anybody can create a social media platform that goes viral. Anybody. Then you people especially interested in primary care, you start accounts they've done all throughout medical school and now in residency, and they've just celebrated their match and their graduation and whatnot. They still have that spark, and you can see it in their posts and in their passion with words below their posts about primary care. And I think those are the people, especially who, just like how our patients can be our biggest advertisers, those are the types of people who will continue to be the advertisements for primary care, especially when so many people are choosing not to go into primary care because of whatever reason. But I think that when you plant that seed and engage with them and have them start thinking about, like you said, you didn't even know about the finances really until you were working in the urgent care, as to how messed up our healthcare system is. When you start engaging with these people in medical school, in residency, year 1, year 2, even year 3, the impact can be so great, because then they can start, networking differently, thinking about, how am I going to plan DPC financially? How am I going to plan DPC location wise? All of those things. When you do have more lead time, sometimes it's good, sometimes it's not. But and there's definitely clearly examples of people who have opened, within 2 months, they were open and hitting the ground running. But I will say that if you can plan financially and build your dream practice with fewer things, trying to fight for that space at the beginning, it can be very rewarding starting out like that versus having to scramble.
Yeah.
Now, can you share some tips and tricks that you love to use when you're engaging with the community, whether that be following up in person or following up virtually?
So, first of all, numbers don't mean anything. They really don't, because you can buy followers. They only matter for one thing, which is if you want to, and this is a conversation that will come up later, but if you want to monetize your social media, then to some extent, numbers matter, because the more followers you have, the higher you can make when you want to monetize, whether you're working with brands or putting out posts or whatnot. That's the only reason numbers matter. So if you're trying to build your practice and find your patients, you can do that with, 100 followers. You can find patients, however many, because all it matters is who you're connecting with, right? So when you go on there and you see all these big numbers, don't let it intimidate you, because again, if you're not trying to get paid, then it doesn't matter. If you're there to say something, then you want to try to find the people who want to hear, right, what you want to say. So in terms of tips and tricks, think when you're making content, try to ask yourself, is it about me, or is it something that can be of value to someone else? And you can certainly do a bit of both, because people like to hear your story, but you always want to try to give people something, whether it's something funny or just something entertaining, or it's a little kernel of wisdom or a little tip that you got from your experience, so that they're not just reading you being indulgent about yourself. There's a message or something helpful in there, even if it's just how you reacted to this patient experience, or how it affected you. So try to give some value. I think that's very important. Another thing is, think about the different ways that you're going to put content out there. We all understand, I think, what a post is, that there's a photo and then you write a caption underneath about the photo. It could be 2 lines, it could be 4 paragraphs about, and the two don't even really need to match. It just depends on, what are you trying to put out there, right? But video content is really, really important right now. So if you're going to make the leap, it makes sense to start learning how to create video content from the beginning. I am not a video person. I don't like hearing myself talk. I have had to get over it and learn how to communicate on camera, because that is what is being pushed. And when you get into things like looking at the analytics of how many people looked at a post, it's not even comparable. It is like 10 times as much for a reel versus a post. Even if it's a tiny little reel of you showing yourself walking with your dog, it will blow up compared to a post that you spent so long writing, but it's just a static post. So definitely learn about video content. And then the third thing I would say is just jump in and start engaging with people, because there's a bit of an etiquette to it, but it starts with just someone writes a post, reading it and putting a comment that's genuine. It could be as short as, I love the message in this. It could be as long as, I am so glad you're talking about how hard it is for working women to breastfeed. I wish I would have had more help when I was doing that during residency. So sometimes it could be very deep and insightful, and sometimes it could be just supportive, but that the person writing will notice that you did that, and they will likely put a response, and they will likely say, who is this person? The other thing I would say is also, depending what your goals are, match that to the size of the person's account. If I put an account on Dwayne The Rock Johnson's account, he's never going to see little old me, right? But if I put it on somebody who has maybe less than 10,000 followers or less than 5,000, they're probably reading their comments and they will likely appreciate a new follower. But when you get into people with these big numbers, you may or may not ever hear back from them. They may or may not follow you. And again, it depends on what's your goal. Are you trying to get a big number of followers to get money? Or are you trying to connect with people? In which case, just spend your time finding out whose content just resonates with you, and just say things that are polite and genuine. When they make a story, put something in there, happy birthday. They're posting about their birthday, happy birthday. And you'd be amazed how you can build a connection with people that you've never met in person. And to me, it's astonishing. And I was watching a movie the other day, and one of the characters was being critical about young people using social media. And she was like, you're on these phones, and there's this world, and it's just all fake. You're getting likes from people you've never met, and you're never going to meet in real life. And the thought that crossed my mind is, how is this different from pen pals, right? In the 70s, everyone had a pen pal that was like in Australia. And you were never going to call that pen pal, but you wrote letters, and people sometimes met up and married their pen pal, or they, met them in Europe and did a girls' trip together. And this is the modern day pen pal, and people are looking for connection. So I think as long as you see it in the context of what it is, you can really build relationships that then, you will meet at a conference, or, you might meet somebody and say, hey, I'm going to be in your town. Do you want to grab a cup of coffee? If you think it's appropriate, and if you feel like that's, would be reciprocated. So I think you just have to be mindful of how to use it the best way, and then don't let it get into your head when nobody likes a post, or, something doesn't do well, or nobody follows you. Just tune it out.
Because you said you try to do your content on Wednesdays and Fridays. How much time do you devote to spending on social media?
So every day in the morning, I usually will go in, and then if answer any messages. I'll kind of look at my feed, comment on people tag you, right? So if they've tagged you, comment on those and then look through. And I always try to invest, even if it's just 15 minutes a day, going through and, liking people's posts that I'm connected to or putting a comment on them, supporting their accounts because they will support me back in turn when I post. So I'll usually do that maybe sometime in the morning, sometimes in the lunchtime a little bit if I'm, need a little mental break. And then sometimes in the evening when my kids are not looking at me. And because again, I have to do this on the down low. But then in terms of creating content, it's tricky because the video content can take a while. And it took me a while to figure out how to put things together, how to get the light right in my office and things like that. So maybe I'll say like on Tuesday, I'll put aside like an hour at the end of patients to maybe try to film. And sometimes I just have to do them really quick. All I have is an hour. I'm like, okay, I just have to make something. And sometimes those are the ones that come out great. And then sometimes they don't. And then with Instagram, usually you write a caption. So then writing the caption is a second piece. So then you write the caption, then you put it on the bottom of the reel, and then I'll post it on Wednesday morning or Friday morning. But I've also just started on TikTok just to, make life more exciting. And TikTok is fun because there's really no writing. It's all talking. And so then I had to sort of pivot and say, okay, I want to do things that are different than what's on Instagram. So it's not just repeating. And what I'm finding that I actually like about TikTok when it comes to putting a message out that is geared towards future physicians and young physicians is it's much easier because you can just sit there and start talking and people will ask you questions and you can put their question and then make another TikTok in response to it. So someone asked, can you open a DPC out of residency? And so I think that's what it was. I put it up there and I just answered the question in under 90 seconds. And then, you go back and trim the clips and everything, but there's no long caption to write. So sometimes I can do those really fast because I finished up my work day and I've got half an hour. Let me just I'm already dressed for work. So let me just film a few quickly and then go home. And then on Wednesday or Friday, I'll put them out there. And, I'm old. I am not of the tech generation. So if I can figure this out, everybody can.
Amazing. And the strategies that you've mentioned are, I think, very helpful because you're thinking about it from a physician's perspective who is taking care of patients actively. So I think that that's where your words are golden. Now, in terms of the monetization, during our DPC Summit talk, it was yourself, Dr. Kristen Marie Coleman, and then myself sharing the stage. And you guys really, educated the audience as to how to make social media work for your community, but also how to monetize it. And when you talk about how diversifying can help you so that, especially in monetization, if you have extra income coming in, you might not have to feel rushed to add 5 more patients that month to help cover your overhead. So how do you think about monetization and social media, and how have you made it work for you?
I have just recently started dabbling in it. I did a campaign with GoodRx, which was my first brand collaboration. And I wanted to test it out to see, what is involved? What is it like? How do you even do this? You negotiate the contract. I think the one I did was like a post, a reel, and 5 stories. And I knew how to make all those things, but then making it while talking about a product was new. They want it filmed a certain way. So make sure you follow all the things they want. It took quite a lot of time, to be honest. It was my first one. And I think if you are already starting out younger, and if you're starting this in the year where your practice is still filling and you have downtime, it's the ideal time to start doing it. Me now, it's hard for me to do because I don't really have the right allotment of time to put into that to then pitch the brand and then, find out. And then, all the things that Kristen Marie talks about, which she has experience in. So I am sort of just kind of keeping an eye on it, sort of building that very slowly, but it's not my top priority because my practice is full. So looking after those patients and then managing my home life as well are pretty much taking up all of my time. But I do like the idea of doctors being able to bring that to the table because I think our opinions are very valuable. And I think if you're going to be on social media and you've kind of figured out how the platforms work, that it's also another skill set to build. And there are people, I think, making quite good money. I just don't think I have the space to do it properly in my life right now, is my short answer. But down the road, maybe.
I love that. You are a physician, you are an entrepreneur, you're a DPC owner, and you are a social media queen. So you are listening to your own words and you got started and you're doing it. So jump on those platforms if you're not following her already and follow her today. Her account is at dr.aleeagupta. And it'll be on her accompanying blog at mydpcstory.com as well. And in closing, I want to ask, is there anything else you'd like to share with our audience?
Absolutely. I wanted to just share that in that first year, if your practice takes a long time to build like mine did, that first of all, the things you're doing and the skills you're building are going to serve you for when the practice does get busy. And a year from the time when it seems like it will never happen, you might suddenly be busy and you'll look back and you'll just marvel. But in that first year when it's building, take comfort in, from this podcast and from other DPC docs that you meet, take comfort in the fact that people are doing it and it can be done. I had a local mentor and a friend in Dr. Clodagh Ryan, and I used to repeat to myself like a mantra, if Clodagh can do it, it's possible. Clodagh did it, so it's possible. I told myself that over and over and over and over again because it was true. I mean, she had a living, breathing practice, 3 miles from me, and our counties are huge. Mine is 1 million people. So I know there are like 200 people out of that million that really should be my patient, but it's how am I going to find them and how are they going to find me? And so I kept telling myself, it's possible. Just keep going. And it is. And so I really want other people to believe that because it is the God honest truth. We don't have enough DPC doctors in the country yet, and the patients are there. They just don't know where you are and you don't know where they are. And the other thing I would tell myself, it's going to sound so silly, but you will have bad experiences. You will have patients who join and then it will not work out. It is just the way of it. And I mean, I'm a perfectionist. I think we all are to some extent. And they'll join and then they'll leave, or they'll kind of talk to you, but then they'll decide not to sign up. And I used to just always tell myself, I think it's from, can't remember what movie, it's the genie, Aladdin, right? You'll never have a friend like me. I used to tell myself, you'll never have a doc like me. You'll never have a doc like me. And I would just tell myself that, okay, you'll never have a doc like me. You're going to go on out there and you're going to have somebody else, but they're not going to be as good as I would have been for you. Whether that's true or not, I don't know. But it used to give me comfort because I would say, okay, I know that I am being the best doctor I possibly can for you. And if you don't see that, then okay, so be it. But I know I can be the best doctor you have ever had. I know it. And I think if you tell yourself that as well, it gives you comfort because you will find those patients and then you will be the very best doctor by nature of yourself, your personality, your passion, and what we're doing in DPC. They're never going to have this type of medical care anywhere else. So just kind of hold on to that because the first year, it can be a grind. It can be an uphill grind, but that's why we have this community, and reach out and listen to other people's stories and talk to other people and realize that you're not by yourself and there are people who want to support you and cheer you on. And that's the great and special thing about this DPC community. I know Marielle has spoken about it and I think we all feel it. And so let's just continue to cheer each other on.
Another amen, Dr. Gupta. Thank you so much for sharing your story today. It has already, I'm sure, made a difference in people's lives and will continue to do so in the future. And I can't wait to see you again in person.
Thank you so much, Marielle. This was such a treat, such a joy. I'm so happy to have been on here and I look forward to seeing you again soon too.
Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Marielle Conception.